Good evening, everyone. I'm Dr. Gurusanthiya working as a consultant anesthesiologist in Kumaran Medical Center, Coimbatore. Today, I will be presenting about pulmonary function test and assessment of pulmonary function test in regards to lung resection surgeries. So, in any case, wherever you're given, the outline of a case presentation will always be history taking, physical examination, laboratory investigations, and imaging techniques. But in lung resection surgeries and in surgeries where the POPC is going to be very high, pulmonary function test will actually have an important role. So what are pulmonary function tests? These pulmonary function test is a battery of studies or maneuvers which are performed using a standardized equipments to assess the lung function. See, what are the lung functions which we are going to assess? The first is the lung mechanics, and then is the parenchymal function, and then is a cardiopulmonary interaction, wherein the interaction of lungs with right heart and left heart plays an important role. So these pulmonary function test has got a specific indications where if the patient has got a chronic cough or if the patient is falling short of breath as a dyspneic. So to evaluate their symptoms, a pulmonary function test can be done. And to patients who are at high risk, as in case of any occupational exposure or a patient who is smoking chronically, so who is at risk to develop any disease. So screening of at-risk patients and preoperatively to risk stratify, we can do a PFT, and monitoring drug toxicity, as in case of cytotoxic agents like bleomycin or any pulmonary toxicity agents. Even before the symptoms begin to erupt, these patients can have a change in their pulmonary function test, which can be done on a timely basis to monitor the drug toxicity. And in case of prognostication, we can use the PFT to assess the severity. How do they respond to the therapy? Like if it's a bronchodilator, which is helping or not? What are the treatment goals which are going to achieve with the pulmonary function test? And to categorize the disability as mild, moderate, and severe. In case of preoperative risk stratification, TC has given way back as a indication guidelines like those patients who are more than 70 years, who are morbidly obese, with a history of smoking or cough, undergoing an abdominal or thoracic surgeries, or any pulmonary disease, they have to undergo a PFT. These guidelines were very vast, and hence American College of Chest Physicians has given a clear guidelines wherein patients who are going to undergo a lung resection surgery, who has a history of smoking or dyspnea preoperatively, who are undergoing a cardiac, upper or lower abdominal surgery, and those who have an uncharacterized pulmonary symptoms or to undergo a preoperative pulmonary function test to risk stratify them as high risk, intermediate risk, and low risk for POPC. So what is the contraindication here? Any patient who has got a recent MI or an angina within 1 month, any patient who has got a thoracic or aortic aneurysms, who has an active hemoptysis, of course, they cannot do a PFT, and who has undergone a recent ocular surgery and who has a pneumothorax is actually contraindicated to undergo a pulmonary function test. These pulmonary function tests are classified as bedside pulmonary function test, which will test for vital capacity and dynamic test, and lung mechanics, which includes dynamic and static lung volumes, and parenchymal function, which includes gaseous exchange and diffusion capacity. And next is the cardiopulmonary interaction, which is actually a 6-minute walk test or an oxygen consumption or a cardiopulmonary exercise testing, and which is done least is a split lung function test. And these tests are actually going to form the treelet stool and help in predicting the postoperative outcomes for patients undergoing a cardiac surgery or a thoracotomy. So bedside pulmonary function test, it can either test vital capacity or it can test a vital capacity and dynamic function and others. So those who test the vital capacity alone are subrassus breath holding test, subrassus single breath count test, which assesses both vital capacity and dynamic function are Snyder's match blowing test, forced expiratory time, Debenhams whistle, a right speak expiratory flow meter, Green and Berovich cough test. The others are arterial blood gas analysis, which can give us a clue about oxygenation and ventilation, Pulse oximetry, it gives us a clue about the pulse rate and the oxygenation. And respiratory rate is a bedside pulmonary function test assessment wherein a chronically elevated respiratory rate can lead on to fatigue and it can lead to postoperative hypoxemia. So coming on to the one which assesses the vital capacity alone is a subarachnoid breath holding test. You ask the patient to take a full breath and then hold like this. And then if I'm able to hold the breath for 25 seconds, then I have a normal cardiopulmonary reserve. If it is 15 to 25 seconds, it is a limited cardiopulmonary reserve. And if it is less than 15 seconds, then it's a very poor reserve. This can also assess the vital capacity, as in, if I am able to hold for 20 to 25 seconds, then my vital capacity is somewhere around 3000 ml. If I'm able to hold for 15 to 20 seconds, then my vital capacity is somewhere around 2500 ml. So we can remember it as 20, 25, and 30. 15, 20, and 25, and so on. Any patient who is able to hold for only 10 seconds or less, they have a poor cardiopulmonary reserve. And subarachnoid single breath count test, you actually ask the patient to take a deep breath and then count numbers like 1, 2, 3, 4, 5, 6. So if I'm able to count till 20, then I have a good cardiopulmonary reserve. If I am not able to, then I have a poor reserve. So these are the tests which will assess both the vital capacity and the dynamic function. The first one is the Snyder's match flowing test, which actually estimates the maximum breathing capacity. The patient is asked to sit in a quiet, comfortable room where there is no air movement, with the mouth wide open without pursing the lips, and the ability to blow the match at 9 inches or 15 centimeters is taken, wherein the mouth and the match are at the same level. So if the patient is able to blow at 6 inches, it means the forced expiratory volume is more than 1.6 liters per minute. Then Osland modified as, if the patient is able to blow it at 9 inches, then the maximum breathing capacity is more than 150 liters per minute. And if the patient is able to blow only at 3 inches, then the maximum breathing capacity is more than 40 liters per minute. I think this test will become obsolete in the view of COVID and the influenza pandemic which we are facing right now. So this is a Green and Berovich cough test. The patient is asked to take a deep breath and then cough. The ability of the patient to cough in respect to strength, effectiveness, and productivity of the cough is assessed. If the cough strength is ineffective, the patient is not able to produce any effective cough, then the FEV1 is less than 15 ml per kg, or an FEVC is less than 20 ml per kg, and the peak expiratory flow rate is less than 200 liters per minute, and an ineffective cough predisposes this patient to increased risk of postoperative pulmonary complications. And coming on to forced expiratory time, you ask the patient to take a deep breath and exhale maximally. You keep a stretch over the trachea. Normally, the patient will expire around 3 to 5 seconds. If the patient is exhaling for around more than 6 seconds, then it can mean that the patient can have an obstructive disorder. And if there is a premature termination of expiration, that means the patient has got a restrictive disorder, which is less than 3 seconds. Then is the Light's peak expiratory flow rate and the Debenhams whistle. This peak expiratory flow rate is somewhere around 450 to 700 liters in males and 350 to 500 liters per minute in females. Anything less than 200 liters per minute is predisposing the patient to POPC because the patient will have ineffective cough. This is a peak expiratory flow meter, and this is Debenhams whistle. This is a good old equipment where the maximum leak or the maximum whistle sound where it's heard, that represents the PEFR. So as of now, we have seen only the bedside pulmonary function test, which assesses the vital capacity, and the dynamic function. So the next which we are seeing is the lung mechanics. This lung mechanics is actually seen by spirometry, which is developed by John Hutchinson way back in 1900s, which actually assesses both the static lung volumes and dynamic maneuvers. These static lung volumes and capacities and dynamic maneuvers helps us in assessing the lung mechanics. So in physiology, we would have connected ourselves to a rotating spirogram, where whatever the respiratory movement which we keep will be traced over a paper which we put around the drum, and that is the actual spirometry which John Hutchinson developed. And to have an acceptable spirogram or a spirometer tracing, we need to have an acceptability criteria and a reproducibility criteria. The acceptability criteria is the chart should not have any artifacts. The patient should not breathe in between doing a spirometry, or the patient should not cough or have a premature glottic closure. The exhalation should be at least for 6 seconds in volume time graph with a volume time plateau of at least 1 second, and there should not be any leak. So what is the reproducibility criteria is the largest FVC and the next largest FVC should have only a difference of 200 ml or 0.2 liters. That holds good for the largest FEV1 also. The largest FEV1 and the next largest FEV1 should have a gap of only 200 ml and not more. The patient should be educated very well as to have the spirometer mouthpiece in place and should not have any leaks. And patient should be asked to take a maximum effort on in inspiration as well as in expiration. If the patient is cooperative, can go up to 8 efforts. More than 8 efforts is not actually tolerated because the patient will become fatigued and may not have or may not produce an effective breathing or exhalation in the next further attempts. So if the patient is actually had made 8 attempts and you do not get a acceptability criteria or a reproducibility criteria, it is better to ask the patient to wait for some time and repeat the spirometry or spirogram again after quite some time of rest.